If you guys have that PowerPoint open, we'll go to the first slide. So when I first learned heart rhythms, I didn't know what was going on in the actual heart. I just looked at the strip, I knew what a-fib looked like, and I was ready for my test, and I knew how to choose a-fib and a-flutter. We actually got drunk, and because they sent us to this German city and to do ACLS, and I wasn't going to go to this German city and not go out and party. So we studied drunk. Luckily, the next morning when we took the test, we were still drunk, so we remembered everything. But we were just remembering, like, a-flutter, there's sawtooth patterns. So at a minimum, you could try to just learn those and see if you can pass the test with those. I think just like Dr. Sotos' test, where we had the skin lesions, and he had the exact same pictures from the slides in his test, I would hope that the same will be true, is that every rhythm on the test is a specific rhythm that we've seen in our slideshows or in some of the handouts that she's sent out to us. So at a minimum, you can try to just memorize stuff that way. There's a lot of important stuff I'm going to skip. I'm just going to go over the basics to pass this test, what I think could confuse people on the test. She has all right, so just like we learned a systematic way to remember or to learn acid-base disorders. Is their pH off? Is it a kidney or a lung issue? Is it compensated? Are they hypoxic? And that gives you the full answer. There's a systematic way to read EKGs, okay? She has it listed on her slides. I like what's on my slides here, the bold and underlined, just using rate, rhythm, QRS, and intervals. You guys are going to be able to identify all the rhythms being tested if you just do rate, rhythm, QRS, and intervals. And we'll go over each of those right now. Rate, she goes over how to get rate in her slideshow, so I won't go over it. For rhythm, ask yourself this: is there a P for every QRS and a QRS for every P wave? For QRS, is it wide or narrow? And I'll cover what's happening in the heart to make it wide or narrow to help it make more sense. And what that does is it helps us identify where that rhythm is coming from. And then for intervals, the only interval you need to know for your rhythm strips is your PR interval, because you're going to have your heart blocks have PR interval issues. There is a slide about QT intervals and medications, so I could see you also needed to know how to get a QT interval, and that's in your slides to look that up. But for looking at a rhythm and naming that rhythm, PR interval should be the only one that you have to look for with this method that I'm showing you. So we're going to start with anatomy. All right. I'm going to move this closer.
Yeah.
Can I?
Yeah.
Okay, so this is the heart. The SA node is the primary pacemaker. There's also pacemaker cells all throughout the heart. So there is backup pacemaker cells here and here and down here and here, and there's ones down here, and these are just backups. If they don't get a signal from above, they're going to take over as the primary pacemaker, okay? So this one might take over. If these ones don't get anything from up here, they're going to take over. If you get all the way down to the bottom of the heart and nothing is initiating a pulse, these pacemaker cells down here are going to initiate a pulse. And these are just fail-safes to keep the heart functioning if your SA node fails. All right, they all have an intrinsic rate that they will start a rhythm at. Okay, up here is really easy because it's our normal heart rate parameters for our vital signs. So these ones beat at 60 to 100 beats per minute. This is the junctional area. It's the atrioventricular junction is what it's called. So these rhythms from this area are called junctional rhythms. These foci, which is plural for focus, these foci are junctional foci. And they beat at a rate of 40 to 60. And then all the way down in the ventricles, these foci have an intrinsic rate of 20 to 40 beats per minute. And this is important in helping you try to identify these junctional rhythms these idioventricular rhythms and agonal rhythms, knowing the intrinsic rate of these foci. Now, junctional ones, there is an accelerated junctional. There's a tachycardic junctional, okay? And I'll show you guys how to differ for that when we get to the junctional rhythm. So that's the first thing I want you guys to know about is these pacemaker cells. Second thing I want you to focus on anatomy is we know that the AV junction, there's a natural pause here to allow blood to go into the ventricles before the ventricles contract, okay? Not only is it a natural pause area, but it will not accept an early transmission from the atria. So if this focus, if all three of these are trying to send rhythms and one just went down to the ventricles, the SA node's not gonna let those rhythms through. It's gonna let the ventricles finish up what they're doing, and when an acceptable time has gone by, then it will allow a pulse to go down to the ventricles and pump that blood to the body. Okay, that's the second thing I want you to know about anatomy. This is the location of heart blocks, the AV node. This is your first, second, and third degree heart blocks. There's also bundle branch blocks, which are in these right and left bundle branches. So the first, second, and third degree heart blocks are from the AV node. Okay, third thing is, this is your left bundle branch, and this is your right bundle branch. So coming down from the SA node, it splits into two branches, and it goes up like that, okay? This is important with reading EKGs. When electricity goes in its normal pathway and it goes down these bundle branches, it's super fast. That's why they exist. It's to get electricity down to the ventricles as fast and as coordinated as possible to make one contraction very smooth. So if you have a focus at the bottom of the heart that decides it's gonna become the primary pacemaker, so it's gonna send electricity outside of these bundle branches. So let's say this guy decided he wants to start a heartbeat. He's gonna send electricity up here, up here, up here, here. Maybe it finds its way into the conduction system, and then it goes around and it depolarizes the left side of the heart. It took a long time. Because it took so long, it shows up as a wide QRS on our EKG. So a narrow QRS happens because electricity is shooting down these bundle branches, and the wide QRSs happen because they're coming from somewhere outside of this bundle branch system, and it takes longer for the electricity to get from point A to point B. All right, so to begin, we'll talk about what a dysrhythmia is. So the definition of a dysrhythmia is any alteration in rate, the location of the origin of the heartbeat, regularity, regular or irregular, and an issue with conduction, okay? So like our heart blocks. So those four criteria make it an arrhythmia or dysrhythmia.
Can you repeat that?
Any questions?
Can you repeat what you just said?
Yep.
About the four?
Yeah, so to be a dysrhythmia, it has to have a rate issue, and a regularity issue, come from a different point of origin in the heart, or be a conductive issue, such as our heart blocks. All right, go to slide 2. We have a normal sinus rhythm. So let's use that method that I discussed. Rate. Find out your rate. 1, 2, 3, 4, 5, 6. Looks like it's about 70. That's between 60 and 100. That's a normal heartbeat. So I know it's not a tachyrhythm, and I know it's not a bradyrhythm. Let's try to figure out what else might be going on here. Rhythm, is there a P for every QRS and a QRS for every P? So start with that first QRS complex. So P, QRS, T, P, QRS, T, P, QRS, T. Yes, there's a P for every QRS and a QRS for every P. QRS, is it wide or narrow? It's a narrow QRS. So I know this heart rate came from up here and went through the normal conduction system because it's a narrow QRS. And then intervals. Your beginning of your P wave to the beginning of your QRS is your PR interval, and it's allowed to have 5 of those little boxes or one big box. So on your EKGs, there's the little boxes. PR interval is from here to here, and you're allowed 5 boxes, 5 of those little boxes. And longer than that is a prolonged PR interval. This one does not have that, so I think this is sinus tachycardia, and the name of that comes from the sinoatrial node. That's why we call it sinus, oh sorry, I said tachycardia. Sinus, normal sinus rhythm, okay? Normal SA node initiated rhythm, okay? Now, in the test, I could see there being this heart rhythm, but they don't have a pulse. That's PEA. Looks like a normal heartbeat, but there's not an actual pulse happening. It could just be like it shows up as a big QRS, but it's just a little bit of electricity actually going through the heart, not doing anything. So that's why I put PEA on the bottom there. Okay, next one on slide 3 is bradycardia. Let's go through this systematically. Rate 1, 2, 3, 4, 5. There's 5 on there, which if you use the 6-second strip method, that would give you a rate of 50, but if you read the EKG, it says the heart rate's 37, and that does match another method that I use. So the rate's about 37, so I know it's bradycardia. Rhythm, is there a P for every QRS? P QRST, P QRST, P QRST? Yes. Now you'll see on that line, it's called the isoelectric line, when the electricity turns back to normal. That line, there is some quivering there, okay? People move, the people breathe, it's gonna cause what's called artifact, and that happens, okay? Don't read too much into those little squiggles, okay? Those aren't anything, that's just the patient moving, all right? And then again, you can just remember that this specific rhythm strip is her bradycardia example for the test. Don't look into those little extra quivers. When you see bradycardia, start thinking AV blocks. Those are a slower heartbeat because we're dropping some QRSs, so there's less QRSs per minute, so they're probably gonna have bradycardia, especially with your 2nd degree, 3rd degree. And then sinus tachycardia. So all 3 I went over, those are all initiated at the SA node, okay? It's just whether it's too fast or too slow, which makes it a dysrhythmia. All right, so the rule, all right, let's do it systematically. Rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, about 130. Is there a P for every QRS? Yes. What we're looking at here is a PQRST, PQRST, PQRST. The T and the P are right next to each other. I'll go over what would make this SVT when I get to that slide, all right? Don't confuse this with atrial flutter, where atrial flutter has, we'll get to that slide. It has like 3 bumps and then a QRS and then 3 bumps, okay? Again, a really easy way for this one is to just look at her A flutter picture, and that's probably, hopefully gonna be the same example. I've seen that specific picture over a lot of years. That one keeps popping up whenever I take rhythm strip tests. So hopefully that's the A flutter picture that she puts up there, okay? Just don't confuse those two, because the T wave and the P wave, you could look like A flutter, but it's not, okay? Your clue for the A flutter was there was 3. Okay. Next, SVT. Okay, so the rule for SVT is it's between 150 and 250. And it gets so bad that you can't tell the P waves and the QRS complexes apart from each other. This is the textbook rule for SVT. 150 to 250, and you can't discern between the P waves and the T waves, okay? So you get a QRS, and then you have just something between the two, and then you go back into your next QRS, and then you have something between the two and a QRS. Sometimes they get so close that P and T wave like merging isn't even there. It's like it's narrow. QRS is right next to each other. Okay, so let's go through this systematically. Is there a okay? So rate. .200, okay, that meets the first criteria. So it's a tachycardia rhythm that we're dealing with. Rhythm, is there a P for every QRS? I don't know. Another sign that it might be SVT, because that's a rule for SVT. It's hard to tell if there's a P for every QRS and a QRS for every P, because they're hidden in that weird complex in the middle. But we have a so we don't really know what's going on right now, but we have some more steps still to try to figure this out. QRS, is it wide or narrow? It's narrow. So break down the word supraventricular tachycardia. Supra, above, ventricular, ventricles. So above the ventricles tachycardia. It's a tachycardia coming from the atria, or above the ventricles, more correctly. The full name for this one is PSVT, paroxysmal supraventricular tachycardia, meaning sudden. So another way to determine if it's this or sinus tach, this one would be sitting on the couch and all of a sudden their heart starts firing this fast, okay? So some symptoms go along with diagnosing this versus like sinus tach from a fever. QRS, is it narrow? Yes, so I know it came from up here and went through the normal conduction pathway because I have a narrow QRS, okay? Another sign that it's supraventricular tachycardia. And intervals, I can't see P waves, so I can't get intervals, so we won't worry about that. Notice how organized it is versus when we get to a-fib, how disorganized a-fib is. That'll help you not confuse those two. Okay, any questions so far? We'll do atrial fibrillation next. Okay, so break down the word atrial fibrillation. Fibrillation means muscle twitching, okay? So what happens in a-fib is a bunch of these foci get irritated and they all start quivering or twitching in the heart, okay? So imagine this is my left atria and this is my right atria. It's just quivering happening like this in the heart. And if you look at the rhythm, that makes perfect sense. So you get a bunch of quivering, okay? The AV node isn't letting all those impulses through because that's its job, okay? Eventually, it's time for the ventricles to beat and it lets one through. Oh my goodness, I am doing a number to this board. And then you go back to that quivering, okay? And then eventually, an AV node lets those through, okay? She talks about regular and irregular, okay, so I think everybody was in here, I won't, never mind, for the video, let me repeat it. So, when discussing regular and irregular, we already learned that in health assessment. When you take a pulse, this is a regular rhythm, and then this would be an irregular rhythm. Okay, atrial fibrillation is our only, okay, sorry. Then you take, is it irregular? Well, is there a pattern to that irregularity? And that would be a regularly irregular rhythm? Or is it complete nonsense? In the case of ventricular fibrillation, where it's irregularly irregular. This is the only irregularly irregular rhythm that's in her slideshow. Everyone, does anyone not understand? Okay. All right, now atrial flutter. Let's break down that word again. So the word flutter is literally talking about a bird or a butterfly fluttering its wings, okay? And it kind of looks like that.
Wait, I just want to clarify. The regularly irregular is a-fib.
Irregularly irregular is a-fib.
Okay.
Yep. Okay, so, and I'm not going to mention regularity again because that's the only place it comes up in her slides. So I wouldn't worry about it too much. Okay, so A flutter. This one's pretty cool actually. So what happens in A flutter in the heart is an electrical rhythm or action potential gets started from the SA node. It goes around and depolarizes the atria, and then it ends up just doing a loop on itself, and it goes and does the same exact thing. So as soon as these cells that just depolarized are ready to go again, they're repolarized, it hits them, and then it lets it happen again. Now the AV node is doing its job, and it's not letting this second rhythm come through, okay? Goes around, in this example she gives, it does it 3 times, comes around a 3rd time, and then at this 3rd loop, it allows that one to go through. And it makes perfect sense. That's exactly what it looks like. It's atria contraction, atria contraction, atria contraction, ventricles, okay? And then we do it again. And that's what A flutter is. All right, everyone good? One thing that can help you identify this from a-fib is if you look at these 3 P waves, they all look the same as the next 3 P waves. And then the next 3 P waves. One's kind of pointy and tilts to the left, the next one's more rounded, the 3rd one kind of goes right up to the QRS, and then the QRS happens, and then they kind of repeat itself, okay? So that's your hint. It's not a-fib. There's not a bunch of these different foci doing it. It's just a re-entry circuit is what it's called, okay? Those are your clues. So if you did this systematically, rate 40, I don't think this is a 6-second strip. Rhythm, is there a P for every QRS? No, there's more P's than Q's, okay? So there's more atria, something going on than Q's. PR interval is close, so I don't think it's a heart block, and that's not the reason why there's less QRSs. The PR interval is solid, and then QRS is narrow, so I know it's coming from up here. Okay, just use that method. You can figure this one out that way. Yes.
I was gonna say, on the test, would you stick by the?
I had a bad hearing, sorry.
Oh, I said for the test, would you stick by like the 6-second method? Because like.
Yes. Yeah.
I've had quiz. I think like a lot of the strips weren't 6 seconds, but she still used the 6-second rule. So.
Yeah. Use the 6-second method for her tests. What I'm saying is the example given here, if you were to count the boxes, I don't think it's actually a 6-second strip because this is a rate of 40 with A flutter, and it should be faster than that. So sorry if that's confusing. I shouldn't even have mentioned that, but she should say on the test that this is a 6-second strip because that's what you need to make that rate assessment. So yeah, assume that they are 6 seconds, or hopefully in the test it says it's a 6-second strip. That was just a side comment of my own saying that I don't think this example is using the full 6 seconds of this example. So sorry if that was confusing. Thank you. Okay, 300, 150, 75. So this is between 75 and 60 heart rate. I know that, so I don't think this is a 6-second strip. That's what I meant to say. Thank you for telling me so I can clarify it. All right, next one, junctional. We kind of covered this. So atria is not doing anything, and the AV junction is taking over pacing, okay? So some focus around this area has decided I'm gonna be the primary pacemaker of the heart instead of the SA node. So let's go through it systematically and see if we can figure out what this is. Rate, 1, 2, 3, 4, 5, 6. 60 on this 6-second strip. I'm gonna do a better method. It's between 60 and 50 beats per minute, okay? 60 and 50 beats per minute is what our junctional foci intrinsically beat at. That's our first clue that this is a junctional rhythm, okay? Is that the heart rate is in this range, okay? Rhythm, is there a P for every QRS? No, I don't see a P wave, all right? At least I don't see it before the QRS, all right? That's our second hint that this is coming from somewhere else in the heart, all right? QRS. Is it wide or narrow? So these look, it's kind of hard to tell because I don't know what the T wave is. I think these are narrow. You see the spike up? It's narrow, okay? So that tells me that even though it's in the junk, it's down here somewhere, the electricity is still going through the normal pathway of the heart, okay? So it's keeping that narrow QRS. Now, look at that second QRS complex. When it goes back up for what I would call the T wave, there's like a tip on the top of it. I think that's a P wave hidden in the QRS. And she mentions it in our inner slideshows. You can have an upside down P wave, you can have a P wave hidden. So I'll draw out what's happening to explain that. So as this junctional focus chooses to beat, it sends electricity down here. It also sends electricity up this way. It's just the ventricles got it first, so they contracted. When the atria contracted, you were already in your QRS, so that P wave got hidden in it. Another way this can show up is, she mentions it in her slides but didn't show it, is you can have an upside down QRS, upside down P right next to a QRS. Junctional rhythms can look like that as well. Just use the method I showed, rate, rhythm, QRS, and then interval for this one. There's no P wave I can tell is a P wave. Discernible P waves is what you actually are looking for in EKGs. I don't see a discernible P wave, so I'm not going to worry about a PR interval. Those are your clues to identify the junctional rhythm. These can look like your ventricle rhythms, okay? And that's where you have to use your rate to figure out which one this is. Now, there's also accelerated junctionals that are 60 to 100. There's also junctional tachycardia. And how you would identify these is there's no P wave. We're skipping the atria, okay? Okay, now slide 10, AV blocks. Just remember this rule for a first degree. Okay, so there's four different heart blocks. I wish they'd have just named them first, second, third, and fourth degree, but instead they have first, second, and third degree, and in second degree there's two types, okay? So now we have to remember rhymes to figure out what's what. First degree, the only rule is it's a prolonged PR interval. So your beginning of your P to your QRS is your PR interval, and you're allowed 5 boxes, 5 little boxes. If it's longer than that, it's a prolonged PR interval, and it's a first degree heart block. You'll have to separate this from your second and third degree heart blocks. So with a first degree heart block, you don't drop any QRSs. It's literally just a PR interval prolongation. That's the only rule for it. So you have, let's go systematically through it. Rate is whatever. Rhythm, is there a P for every QRS? Yes. Is there a QRS for every P? Yes. My QRS is narrow, so I know it's coming from the top of the heart. And then intervals. My PR interval is over 5 little boxes, or 0.20 seconds, or 200 milliseconds is what 0.20 seconds is. So I know it's a AV block, and it's first degree because we didn't drop any, okay? Now to second degree, type 1. I don't like the poem that's in the book. I just remember type 1 likes to run. So second degree, type 1, the QRS runs away from the P wave. So you start out really close, and then gets a little bit further away from the QRS. PR interval gets longer, and then eventually you'll drop a QRS, and then you'll start all over with another P, okay? So let's go through it systematically. Rate, 5, 50, if it's a 6-second strip. That's your first hint that it might be a heart block, is it's a bradycardic rhythm. Rhythm, is there a P for every QRS? No, I have 1 extra P than I have QRSs. So that's my hint that it's probably not a type or a first degree, it's probably one of the type 2s, or sorry, second degrees. QRS is narrow, so I know it's coming from the SA node. And then my interval. So look at these intervals. First one is a prolonged PR interval to begin with, so I know it's a heart block, at least a first degree heart block. And then you follow through and look at these PR intervals. Do they get longer or do they run? So if it's running, 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 drop, type 1 likes to run. Second degree, type 1. All right, now slide 12, second degree, type 2. I would remember the names that are associated with these, Wenckebach and Mobitz, in case those come up on the test. Second degree, type 2, sticks like glue. So in this one, it's just like that type 1, except for you don't get a longer and longer and longer PR interval, you just drop a QRS, okay? I won't draw this one out. So let's go through it systematically. Rate, up top looks like a ventricular rate of, let's use the bottom example. Ventricular rate of 50, bradycardia, first hint that it might be a block. Rhythm, P for every QRS, PQRST, 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 P, PQRST, PQRS, all right? So I have more P's than QRS's. It's our second clue that this is probably a heart block. QRS is narrow, so I know it's at least the heart is starting from up here, going through the normal conduction pathway. And then intervals, I can measure these intervals. He doesn't have a prolonged PR interval on the bottom, okay? So pay attention to that. They don't have to have a prolonged PR interval. It's the dropping of the QRS that makes it the heart block. And physiologically what's happening is the AV node is sick and it's not letting all those impulses through. And it's doing so in a pattern to where it's letting them through, drop, through, drop, okay? That's your second degree type 2. Before we go to third degrees, let's go over some rhythms that could be confusing to these heart blocks, okay? They're sinus arrest. Let's do sinus arrest methodically, okay? Rate, 40. Rhythm, there's a P for every QRS and a QRS for every P. It's a narrow QRS, so it's coming from the sinus node, sinus arrest. And intervals look good to me. If it was a prolonged PR interval, it'd be a type 1 heart block or a first degree heart block, okay? This kind of happens when you breathe. It's called sinus arrhythmia. Take a deep breath, let it out. Your heart pauses and then it beats. It has to do with blood filling in your heart. When you breathe, the negative pressure pulls more blood in. It happens when you breathe. So in her slide, she says it happens when you sleep as well. So don't get this one confused. What helps you identify this one, you can memorize the way it looks for the test, but there's no P to QRS mismatch. There's a P for every QRS and QRS for every P. All right, next one is a premature atrial contraction. I guess we're back where we started, huh? All right, so in a premature atrial contraction, your irritable focus is up in the top. So your SA node beats, sends a normal heartbeat down, and then this guy over here says, oh, I want to do that, and then this one starts a heartbeat, okay? It happens faster than it was supposed to happen, okay? The P waves should look different because it came from a different place in the heart. This one's not a great example of that. They look pretty similar to me, but if you could zoom in, you'd probably find a difference. Sometimes they're super different. So that's what a premature atrial contraction is. If you use my method, you don't have a P to Q mismatch. There's the same amount of P's to Q's, okay? And that's your hint that it's not a heart block. Even though there is that pause after that early beat. And it's just because your body naturally has to pause after the heartbeats to get ready for the next heartbeat. So that's not really a pause, it's your body's normal pause. Those are PACs, don't confuse those. Slide 14, third degree AV block. You guys were all in here for this. You can stay if you want to, but I understand if you if you understood this until I finished. This is where I started, and it's fine that I'm filming if you guys leave, but I'm gonna keep going for the video and for whoever wants to. And I'm also not gonna leave until you guys are good. If you want questions at the end of this, I'll stay and help till you guys are all good. Okay, 3rd degree heart block. I don't know the answer to this, but I would assume as people get more and more sick, you would progress from like a 1st degree to a 3rd degree heart block, because they all kind of go in order of sicker, like less sick to more sick, okay? So in a 3rd degree heart block, the AV node is not working at all, okay? So the AV node doesn't work. No electricity goes through it, all right? Because of that, there's a pacemaker up in the atria that's taking care of the atria, and a pacemaker down in the ventricles that's taking care of the ventricles, okay? The way the heart works is it has fail-safes in case something like this happens to keep itself alive, okay? So what you can do is find 2 P waves. So look on slide 14, 3rd degree AV block. Find 2 P waves that you know are P waves. So I'm gonna choose those 2 that are between the first R waves. RR, there's 2 P's in there, 2 P waves. I would take a piece of paper and I would draw that distance on that piece of paper. And then I would slide that piece of paper over and I would find that next P wave, and it should line up in a 3rd degree heart block. Slide it over again, and then those P waves will keep lining up. You guys might also find as you're doing this that some of the P waves are in QRSs, and in that case, they're pretty easily identifiable when you use this paper method. To confirm this, you'll also do this paper method with your QRS. So find 2 QRSs, take a separate piece of paper, draw little marks from one QRS to the next QRS, slide that piece of paper over, and your next QRS should line up. This one's easy because it's pretty obvious that the QRSs are the same distance apart. Just keep in mind that P waves can be hidden. So it's complete disassociation between the atria and ventricles, your 3rd degree heart blocks. Let's do it systematically real quick. Rate is 30. That makes sense for the ventricles pacing themselves. Our first clue. Rhythm, a P for every QRS? No, I have way too many P's than my QRSs, all right? As you see that, you can kind of have an idea in your head. Are they related at all? No, okay? Eventually, when you look at these, you can spot it and say 3rd degree heart block without having to do the paper method. You can just tell, or use your fingers real quick to do it. But it's pretty obvious. Rate, rhythm, QRS, it's narrow. No, sorry. These are wide QRSs. So I know that at least the ventricle part of this EKG is coming from down below. Our next hint that it's ventricular, like in nature, it's also atrial in nature because of the P waves. So those are your clues that it's maybe a 3rd degree heart block. And then intervals, there is a PR interval, but it keeps changing. By now you should have figured out it was a 3rd degree heart block, no association whatsoever, and then just confirm with that paper method. That's what I always use on my dysrhythmia tests. Everyone good on the heart blocks? Okay, are you guys gonna use one likes to run and type 2 sticks like glue? I knew other ones in the past, and these are the ones that worked for me that I still remember to this day. So I like those ones. All right, so v-tach is our next one, slide 15. So in ventricular tachycardia, there is a focus down in the ventricles that has decided it's gonna take over pacing. And that could be for a bunch of reasons. The person's about to die, and the ventricles are like, okay, I'm gonna try to fix this. So this one focus takes over, and it doesn't beat at its intrinsic rate. This is a really sick person. So the focus sends electricity to the whole heart and tries to be that primary pacemaker. So let's go through systematically and see if we can figure that out with the method. So rate, I think I said earlier, was about 200. Rhythm, P, I don't see P waves, so I know that these are QRSs. This is probably from the ventricles. And then QRS is wide. That's my hint that it's ventricular rhythm. And then intervals, doesn't matter because I don't have a P wave to judge intervals off of. And then remember that this rhythm goes out. It doesn't follow the normal pathway of conduction, so it takes longer to get over here and go all the way around here and wrap around this way and finally depolarize all these cells in the heart, so it makes a wide QRS. And as soon as that one QRS is done, the next one's coming, okay? The body's trying to keep itself alive. There is a version of this with a pulse and a version of this without a pulse. So there's two types of v-tach. There's v-tach with a pulse and v-tach without a pulse. They both can get shocked. They get different types of shocks. With a defibrillator, we would do a different type of shock. By inner slides, they're both shockable rhythms, which is true. That's all you need to know about is that v-tach can be shocked. Okay, another term for this is monomorphic v-tach. Mono meaning one, morphic is like the origin. There's only one focus with this type of v-tach. It's monomorphic v-tach, okay? Now, the next one's torsades. Another term for torsades is multifocal v-tach. So instead of it just being one focus that's irritated and has started taking over pacing, this one's gonna beat, and then the next one next to it beats, and then this one beats, but they go in order. It's not like a-fib where it's fibrillation, where we're not talking about ventricular fibrillation, we're talking about ventricular tachycardia, okay? This one beats, this one beats, this one beats, then this one, and this one, and this one, and this one, and then it causes a twisting of the points. So you get your crescendo, decrescendo, maybe a little one, and then a bigger one, okay? These are just taking turns, and it's twisting or moving of the points, points being the foci in the heart, twisting of the points, torsades. Next slide, 17, is ventricular fibrillation. Now, if you look at this, there is a little bit of like twisting in this rhythm, but it's not adequate, or these electrical rhythms wouldn't actually be able to make the heart pump. These are small, it's more like a twitching. And if you really look at it, you can see how this one's more twitchy than torsades. But don't get confused, because look at it there and agree that there is some twisting along with it, okay? So memorize this picture, that this is the one for v-fib, and then usually torsades is an obvious crescendo, decrescendo, and that'll help you identify the two. So I won't go through the method for these ones. These ones eventually are going to be this one is definitely going to be one of the ones where you're able to look at and identify. And you need to, when you're doing a code, this is a shockable rhythm. So when this pops up, you got to be able to shock this. Also, there's some medications you can give with this one in cardiac arrest. So when this pops up, you got to be ready to give that medication to try to get the meds in the heart when it's doing some acceptable rhythms for those meds. So this is a pretty easy one to eventually learn just by looking at. Okay, next one, idioventricular rhythm. Let's do the method rate. Looks like it's 30. That's your first hint that it's coming from down in the ventricles. Rhythm, P for every QRS. I don't see any P waves. QRS is wide. That's my next two hints that it's coming from the ventricles. Wide QRS, no P waves. And intervals, I don't have a P wave to judge an interval off of, okay? So your hints here are, it's in that intrinsic 20 to 40 range. And then everything else points towards bottom of the heart, okay? So you know it's ventricular. Don't get this confused with agonal. I guarantee an agonal beat is under the classification of idioventricular rhythms. I didn't look it up, and I should have for you guys, but I bet you would find agonal under idioventriculars. Essentially, a focus down in the bottom of the heart, didn't get any impulse, so it decided to become the primary pacemaker and start pacing for the heart. This would probably progress to agonal to your other lethal rhythms, okay? Don't get this confused with junctional. You would use your rate to identify those two separate from each other, distinguish those two from each other. All right. Might as well go over regularity as well. Okay, so I went over irregular on this video, didn't I? Okay, so we're good. Okay. That's all then. Does anyone have any questions? Let me stop the video, and then if you guys want to